Okay, fine. So I won't keep you long. So let's get started with, and on huge request, I will give again an overview on part two first, and then we are going to cover two very beautiful talk articles. And we are going to discuss acute coronary syndrome in pregnancy talk article, as well as we will do tuberculosis in pregnancy, management of tuberculosis in pregnancy. Relatively very new talk articles and interesting as well. So hopefully we will have a very good session. So am I audible and is everything clear? Is there any noise? Voice is clear? Everything? Okay, okay. Thank you, thank you, thank you. Okay, so let's get started. Okay, brilliant, Sobia. Thank you. Thank you, Baba. Thank you, Anam. Okay, so let's have a quick overview about part two, because I can see so many candidates which feel they are lost, and which is, they pretty understandable. But the thing is, if we are going to be with the same feeling that we are lost, we are lost, we are lost. So of course, I mean, we cannot stand anywhere, right? So we have to start from somewhere. We have to take a fresh start in, I must say. Okay. So we are going to talk about, in general. So I'll be little quick for that section, and then we are going to do our discussion in depth, because I really want all of you to discuss acute coronary syndrome as well as tuberculosis in pregnancy with me. Okay. So you guys know me that, we are going to be starting, the things. Okay. So this is going to be basically because we run a course as well. So January 2024 batch. So I can see a couple of candidates are here as well from the course. And then we are going to discuss the management. Okay. And I'm sure, you guys know me. If somebody doesn't know me, so this is me, Dr. Zaib Qureshi. Okay. So I am from Pakistan. Okay. So I did my one fellowship from Pakistan. Then I did MRCOG from UK. Then I did MRCPI, OPS and Gynae, Ireland. And then I did European board as well. Okay. So hopefully, the guys who know me, and they know me and my style of teaching as well. Okay. So the candidates who are with me, I'm sure we are going to have good time, and, we are going to study together. We are going to learn together and grow together as well. Okay. So first of all, my opening, the statement, there is no shortcut to be successful. Okay. So first thing first, you guys need to understand this thing properly. There is no shortcut. All right. So the candidates who literally look for shortcuts, literally look for so many, the things which, I mean, they don't want to do, or maybe, because of one or the other reason. But part two is so extensive. Okay. Part two is so extensive. And, they mark my words that part two is a bridge. All right. So once you are going to be in the flow of studying this MRCOG part two, you will learn that how extensive this MRCOG itself is. Okay. It is way and extremely different from part one. And of course, part three is not like, I mean, comparable to part two. But yes, part two studies are going to be helpful and in part three. All right. So first thing first, you need to think of that there is no shortcut to be successful. You need to work hard. You need to give your time. You need to give your energies, but in the right direction, in a focused manner. Okay. Otherwise, you definitely will be lost, because, the syllabus is so huge. We have been there. Okay. I have been there myself as a student, and, more or less for all boards, studies have been same. So I've been through, I don't know, countless exams, right? So I know, the what exactly we really want to know about this, the particular exam. In terms of MRCOG, if we, the talk about, so this is very competitive exam. Okay. This has been competitive. And since, the candidates are, the getting so and so intrigued about MRCOG, and, the aiming to become MRCOG as well. So of course, competition is there. All right. So don't always think that you are only one in this MRCOG journey. No, there are so many candidates. There are so many good and big brains all around the globe you have to compete with. Okay. So make sure that you are preparing yourself up to that level. Okay. So if I'm from Pakistan, so it doesn't mean that I have to compete my Pakistan candidates only. All right. So I have to compete with, the candidates all around the globe. So first thing first, don't look for shortcuts. Okay. Study hard, study smart, and stay focused. These three things should ever be on your tips all the time. Okay. So don't get, the overwhelmed. Yes, it can be overwhelming at times, but the thing is, you have to overcome that overwhelmness, and you have to do it, okay? Because you are in this boat. So what you will do? Either you will sail, or either you will, drown. So what you need to do? We have to sail through, isn't it? So we have to go, we have to become MRCOG, and of course, once you will become MRCOG, you will be, the confident, you will be, kind of a successful as well, successful person as well. In the end, what exactly we want to be? What's your aim? If I ask anybody that why do you want to do MRCOG, what's your answer is going to be? Anyone, just one answer. So I would be very happy that you guys are so clear in your the paths, and you know what exactly you have to do. So what is your motive? Anyone? Why you want to become MRCOG? If I ask anyone, anyone can answer for this. No answer? Uh-huh. Ma'am, it's my passion. Okay, brilliant. Here you go. Okay, if it is a passion, so of course, what you need to put extra effort, you need to study hard, you need to study smart, you need to be prepared of, the everything there is. All right. Like I said, that, this MRCOG is so competitive now. It's not an easy exam. Okay. So it's not going to be, yeah, Arjumant, very good. Thank you so much. This has been my, the thoughts all the time when I was studying for MRCOG part 2. Because me myself have always, because I was not, the obstetrics and gynecology candidate at all. I have been an internal medicine candidate first, and then, I switched to this OBG. All right. So of course, when I started off my the preparation for the my local fellowship, then I felt after that, no, I have to do something else. Then I started studying for this MRCOG, and then of course it was tough for me as well. Okay, people say that you are a teacher, and you know so many things. No, I was a student once, exactly like you, isn't it? So I had to put my extra effort. Part 1 was in first go, part 2 had to be into the trials, and then part 3 again in 2 trials. Okay, so it doesn't mean that if I'm failing in an exam, so it is decreasing my spark, or it is making me less successful, or it is making me the kind of a very the inferior candidate who cannot even pass any exam. Anjali, very good. Because we need to be updated all the time, isn't it? So end result is what? We need to be very good for our own community, for our own patients, isn't it? So RCOG has got standardized guidelines. So if we do follow those standardized guidelines, so trust me, we can be so, the helpful for our own patients, isn't it? So end of the day, what exactly do you need? You need to serve, you need to serve your community. Afterwards, after doing MRCOG, you're not going to sit at home idly, and you're not just going to sit for I don't know what. Of course, you are going to apply whatever you have learned, isn't it? So first thing first, again, so once you start your studies for MRCOG part 2, number 1, don't be upset about curriculum at all. Once you are going to be in flow, so of course you are going to learn so many things. You are going to be like, okay, and by the end of your preparation, you will be able to collaborate so many guidelines, talk articles into one question as well. This is the beauty of, the thorough studies, isn't it? So what you need to do is don't look for shortcuts at all. Okay. So if you are going to be utilizing my notes, okay, I'll be happily sharing it with you, but maybe those notes are useless for you because you already know that information. Maybe I was lacking in that information, so how come the my notes or my the summaries or anything can be the useful for you? Maybe to some extent, maybe not at all, isn't it? So first thing first, the no, don't look for any shortcut to be successful. Work hard, work smart, and stay focused. All right. So this has to be all the time on your mind, guys. Okay, so never think that if somebody has passed this exam, so he or she was very good because I have failed this exam, so I'm not a good candidate. Everybody is good candidate, isn't it? Maybe it's not right time, maybe your preparation was bit lacking, maybe that was not your day. Because what brings the change in your result? Exam day only. Not your preparation, not number of courses, not number of hours you have studied so far, not number of I don't know countless sessions you have attended, isn't it? So what exactly is going to the work on that day, particular day, is your nerves. So this exam is basically exam of your nerves, because on that particular day you have to utilize your all neurons. So if your neurons are already tired, so what you will do in exam? Nothing. Okay, you will be, of course, once you are going to do any mistake, you will realize it yourself and you will say, oh my God, I did a mistake, so I cannot pass this exam. And this happens. And this happens, which is very natural, isn't it? So, the first of all, they don't be demotivated at all. Don't look for shortcuts. Stay motivated, stay focused, stay calm. Because if you are going to be like, panicking all the time, oh my God, from where to do this? See, help is available everywhere. We have got plenty of the groups around, okay, on almost all social media platforms, isn't it? Back in 2018, when I particularly was preparing for my exam, we just had only the Facebook group, and we didn't have the any concept of any course or anything, but still we used to study, and trust me, the batch we were in together, so the almost all are MRCOG today. Okay, maybe it took like a while to become MRCOG. Okay, but still today they all are MRCOG. So it doesn't mean that you just need to look for anything. Yes, courses can be helpful, teachers can be helpful, because we can guide you properly that, okay, look, you have to put more emphasis on this point because this look like an exam scenario or exam question. All right, so but for you as an exam candidate, be prepared for every kind of question, because we don't know what exactly is going to be on exam day. But if your concepts are clear, if you have studied thoroughly, if you know from where this question came, so this is not a surprise, all the time in exam, isn't it? Exam is not going to be out of the box. Exam is not going to be out of the syllabus. This is us, maybe, who has never touched that part of, the question in our preparation. All right. So your preparation should be very thorough. All right. So first of all, let me just give you an overview that, we have got, the module list as well for part 2. So we do have modules, isn't it? So we do have modules: clinical skills, teaching, appraisal and assessment, information technology, clinical governance. So they do all overlap. And then, we do get a couple of questions. Core surgical skills, post-operative care, yes, they overlap as well. Surgical procedures as well. Antenatal care, maternal medicine, huge module, important module, theoretically as well as clinically, because we do deal with maternal medicine on daily basis if you guys are practicing OBG, isn't it? So we do deal with diabetes, hypertension, asthma, we do deal with thyroid disorders, we do deal with a couple of other autoimmune disorders as well. So this MRCOG itself gives us an opportunity that we study all these topics properly. Then, we bring that information into our clinical, the setting. And then, we be a very good doctor to our patients as well. Okay. So management of labor and delivery, they overlap. Postpartum problem, there are going to be gynecological problems, fertility, sexual and reproductive health, early pregnancy care, gynecological oncology, urogynecology, and pelvic floor problems. I think all modules are familiar, isn't it? So first of all, what you need to understand is, you need to understand that, okay, I have to study, this smartly. I have to pick, the modules which are very much important. Okay. And which carries the bulk out of your preparation. All right. So how we are going to, start? Please mute yourself, everybody. Okay. So for the paper, we have got 2 papers, paper 1, paper 2, and exam pattern. Everybody knows that for part 2, again, let me be specific again, and be repetitive again. Part 1 is way different than part 2. Don't compare both parts all the time. Okay, first of all. So yes, you have passed that part 1. Okay, brilliant. Now you are in part 2. So try to learn the differences between part 1 and part 2, and try to, the study accordingly. Okay, because every exam has different dynamics, isn't it? So paper 1, paper 2, we are going to have 2 papers for, the 3 hours each. All right. And out of, the 100 questions, total 100 questions are going to be there. 50 are going to be SPA, single best answers, and 50 are going to be extended match questions. All right. Single best answers sometimes may look very easy, because by looking at them, you probably know the answer. Okay. By just, the one glance. But EMQs are tricky. And these EMQs are very much important in your exam, because they carry almost 60% of your result, pass marks. All right. So eventually you have to, the attempt 100% question, 100, the each, 100 in paper 1 and 100 in paper 2. So yes, roughly, but out of that 100%, 60% marks will be carried by EMQs, extended match questions, and then 40% are going to be with single best answers. Okay, because exam is of 3 hours, so roughly we, the all mentors, we suggest that at least you give, the for 50 questions you give, the 1 or 1.1.5 minute to one question, but not more than that, because extended match questions will take time. And if you, they roughly divide your 3 hours, so roughly you have to give 1 10 minutes. Okay, 1 10 minutes at least, 1 hour and 40 minutes at least to solve your EMQs, because EMQ needs a lot of, the energy. EMQ needs a lot of focus as well, and EMQs is demanding. Okay, because you have to scan all questions from A to Z. For example, you have given the question that what exactly you have to do, and then you are going to be asked with 1 2 3 scenarios that, okay, out of 1 2 3, A, B, C, D, E, F, G, blah, 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 you have to choose. So for one question, you are going to scan all options. Then for second question, you are going to scan again, and you are going to repeat the same for question number 3. That's why it needs a lot of, the time. That's why it is very much recommended that when you solve your questions, okay, so train yourself that this is how you have to solve in real exam as well. So you can see that, whatever you have studied so far in your preparation, that particular exam day is going to decide your fate. Okay, so clear everyone this part? Any question out from here? Clear? I presume it is clear. Okay, brilliant, brilliant. All right, all right. Okay, so after that, we have said earlier that 60% exam pass marks are going to be for EMQs, and 40% are going to be carried by single best answers. All right. Now let's talk about syllabus again. Although I've been talking, the couple of times, but it's better because we do have freshers as well. So I'll be a little quick. So first of all, you need to understand, we have been giving our exams, throughout our life, isn't it? So how do we prepare? We start from bulk. Okay, we start from important. Remember when we were, in our childhood, we used to do guest papers. Okay, these questions are going to come in exam, these questions are not going to come in exam, isn't it? So but for this MRCOG syllabus as well, we already know that we have to cover first major bulk, because we are into Royal College of Obstetrics and, the gynecologist exam. So what exactly we need to cover? We need to cover, first of all, their own guideline. All right, RCOG green top guidelines. We call them as, the more commonly GTG. Everybody is like GTG, GTG, GTG. Okay, so we are going to cover green top guideline, and then we are going to cover, the important NICE guidelines as well. All right, so both are standardized guideline which we need to follow. All right, and that makes around 60 to 70% of curriculum. Now we are just going to divide what we have to focus first. Okay, so for example, if we take 60% of our 100%, so we are left with only 40%, isn't it? So 40% are going to be covered by TOG articles, 30% maybe, and rest 10% will be covered by, this is rough estimate. This distribution has not been given anyone, and this is not, the official. Okay, this is what we have understood so far in our, the teaching career. All right, so TOG articles roughly can make, the 30% of your 100%. Then, the some important infection guideline, we call them as, the British Association of Sexual and Reproductive Health and HIV. Then we have got, the NHSCP colposcopy guideline. Then we do have FSRH guidelines, important topics only, minded, because itself FSRH is a degree, diploma. Okay, so we can't be, the doing any diploma in our MRCOG curriculum. So what we need to study is, we just need to study important topics only. Okay, otherwise, if anyone who is really interested in doing FSRH can go to UK, can have GMC, and then start doing, the FSRH guide, the DFSRH. Okay, so don't waste unnecessary time. So what exactly you need to focus on? Your major bulk first. If your major bulk is covered, then you are going to cover rest of the topics. All right, TOG article 3 to 5 years are recommended. However, it's better that if you are studying module wise, okay, So you have to cover, the all important talk articles from modules. Okay, because if you just focus on, and if somebody knows curriculum already, so you guys know that the maternal medicine topics mostly are from talk articles. We don't have any other source because we can't go out of our curriculum, isn't it? So like the if I talk about maternal medicine, very huge module, okay, very important one as well. So out of the maternal module, you do have green top guidelines, you do have nice guidelines, but rest of the maternal medicine disorders you have to cover from talk article. And doesn't matter if it is from 2023, like today we are going to discuss, okay, two topics, or maybe it can be from 2010, 2012 as well, because we don't have any other source. Okay, we don't have any other source, so we have to cover. Okay, so we do have consent advices. Consent advices are advices. Consent, as you can see, that when we are going to take patients to theater, so we do have to take consent, and this is going to be kind of numbers all the time. And yes, we do have couple of consent advices, so it is very much advisable that you do summary, and summary is going to the be like, okay, you don't have to go through. And I have already uploaded my own summary on MRCOG part 2 guide group, so you guys can download it from there as well, and the study. So some good practice papers, some good practice, not all. And all these consent advices and the dog these green top guideline, they are all are freely downloadable, and the printable from RCOG guide, the website itself. So you guys can log on to www. Don't look here and there. Be your own guide. Be your own the help, because everybody is the more or less familiar with at least mobile, isn't it? So you guys can Google, you guys can the use anything, www.rcog.org.uk. If you have to do nice guideline, you are going to replace this RCOG with nice NICE. You will get the all guidelines. You guys can print it, you guys can download it, make your folders on your laptop, desktop, or the iPad, wherever you guys want to. Okay, and if somebody is like, the kind of the like, hard copy person, you guys can buy your own the printer, and you can print it yourself. Then like I said, we do have 60 plus green top guidelines, and they all are the starting from, sorry, 2023. Latest guideline is recurrent miscarriage. Okay, latest guideline is recurrent miscarriage, which was published on, I think, 27th of June 2023. Okay, so that's why it is very much advisable that you always Google, you always the look for the RCOG website yourself. Don't rely on the printed material. Okay, that was printed in 2019. Day before yesterday, I got a message from a candidate that, ma'am, I do have the printed copies, and those guidelines are till 2019. Okay, so I would never suggest that you have to do the anything. Okay, that you have to do anything printed. It's very much advisable that you always look for the new version from RCOG website itself. All right, maybe anything can be like, reviewed, or the anything can be archived, anything can be the updated version, or anything. All right, like 2000, this is the RCOG guideline, the RCOG website. You will have the section 2022 section, 2023 section. Okay, so this is how it is going to be: intrahepatic cholestasis, cervical cerclage, steroids, VTE, malaria in pregnancy prevention, and all right. So there are going to be countless numbers of guidelines, and I think they are roughly 60 plus if I'm not wrong. Okay, so how you are going to read guideline, very important. Okay, very important that at least once you go through in your life one guideline completely, because at least you have to have a knowledge about that particular guideline. So how you are going to read a guideline yourself? You have to first of all read thoroughly. You have to note down recommendations if you think there are any. You have to, and then this is another thing. In some guidelines, you are going to see algorithms in the end of the guideline. Okay, this is what I used to do was I used to make a separate folder of algorithms. For example, I had, to study this VTE guideline today. All right. So before going to work in the morning, I got that VTE guideline printed. So of course, algorithms were there. So I used to do, the separate folder of all algorithms. So in the end of preparation, I had my own set of algorithms from NICE guideline, from Green Top guideline, from even, the TOG article as well. I used to print them myself, okay, and I used to keep it a folder. And till date, although I'm an old MRCOG now, but till date, I do open my own notes, my, the every folder, and wherever I have to look for any, the reference or something. So I do use that. Okay, so you guys can also do that. Make your life easy. Okay, jot down your important points if you really want to. If you don't want to, okay, you can skip it, because everybody has a different pattern, isn't it? So I used to note down, because I was very poor in number, so I used to write, incidence, prevalence, recurrence. However, in last two exams, RCOG is not very peculiar about numbers. But yes, for you as an exam candidate, you need to be prepared. You don't know what exactly is going to come. Nobody can predict, isn't it? So at least you have to be 100% on your part. Rest, nobody knows what exactly is going to come in exam. All right. So roughly, you can make separate folders. Okay. You can make, the separate notebooks. Okay. For example, this is for maternal medicine module, MMD. This is early pregnancy module. Or you can even make, the columns or separate section in one notebook, all up to you. All right. So this is how you have to do. And this is very smart way of studies as well. NICE guideline, roughly 15 to 20 guidelines, and very important guidelines. Diabetes, management of diabetes in pregnancy, management of hypertension in pregnancy. All right. Then you have got labor guidelines, all labor guidelines. You have got subfertility module. You have got urogynecology module as a whole. So all these, the guidelines are going to be present in the, NICE website. So what you need to do, you need to use Google, isn't it? And again, I would say, because recently NICE guideline has been, the updated as well. And the recent update is NICE guideline. Let me tell you, because you guys are, the January exam taker. So, the recent NICE guideline updated is cesarean section guideline. If anybody who hasn't gone through, the cesarean section guideline, so I would very much advise that please do revise everything from scratch again. All right, for January exam. Okay, so always look for which guideline has been updated, which guideline has been archived, which guideline has been replaced by, the any of the other guideline or TOG article, because RCOG gives that in there, on the website as well. Okay, this has been archived, this has been replaced, like this. All right. So make sure that you are utilizing, your time, your, the Google very smartly. Like I said, diabetes mellitus, hypertension, subfertility, urogynecology, cesarean section, and labor guideline, menopause guideline as well, isn't it? So almost all important guidelines are NICE guideline. And how you are going to read, the NICE guidelines? So NICE guidelines are going to be, you have to read each line carefully. NICE guidelines are not nice. I'm sorry. It's just, the NICE only. Name is NICE. All right. So NICE in the sense, because RCOG is very clear. This thing you have to do, this thing you don't have to do. But for NICE guideline, you have to study once, twice, or maybe thrice to get a good hold on that particular topic. Okay. So you have to read each line carefully. You have to focus on some words. There are going to be some words as offer, consider, and discuss. All right. Then, of course, you need to memorize. We don't have any other syllabus. Please, I read guidelines again. Well, I don't know your name, but if you are, the retaker, okay, or and if you have to repeat the exam, I would suggest it's a good idea that, you at least go through all updated version. Okay, because maybe, the few things which you don't know from, the previous one, so that will be clear. Okay, Khulud, my voice is interrupted, or am I clear? Let me check. Amara, very good. Okay, Henrik. Okay. I think you have to join back again. All right. Okay, thank you, Mera. Thank you. All right. So this is what you have to study. Nice guideline. Thank you, Noor. Thank you, thank you, thank you, everyone. All right. Hi, Lina. Rabia, thank you. All right. Okay. Talk article. Very, very familiar one. Whenever you will see this green background anywhere, always think of, okay, this is from TOG article. Okay. So by the end of your preparation, you will be able to at least, the understand, okay, which part, which book, which guideline, which TOG article. Okay. And trust me, this is going to happen. Okay, eventually this is going to happen because we are studying, we are living our life as an MRCOG candidate, of course. So by the end of our preparation, we'll be able to put almost all the scattered information into one place, into one question. All right, so don't be overwhelmed. Okay, don't get upset. Don't be like, kind of the stressed all the time. Stress is not going to help you anyway. all Nonetheless, this is just going to demotivate you all the time, and you may be losing your the interest and energy as well. So don't be upset. Okay, start over. Okay, so this is not the end, even if you didn't go through this time. All right, so this is not the end of life. All right, so at least as a whole you have to cover 3 to 5 years of TOG articles, and rest of the the topics which are in the old TOG article. Like I said earlier, that we have got almost 50% of the maternal medicine topics from TOG articles. All right. Cystic fibrosis, headache, enhanced recovery program, nerve injuries, spinal cord injuries, skin eruptions in pregnancy, hyperprolactinemia, surrogacy, SLE, incision sutures, abdominal cerclage, myocardial infarction, which has been replaced by, today's talk, acute coronary syndrome, bariatric surgery, thyroid function, borderline ovarian tumors, polyhydramnios, asthma, liver masses in pregnancy, fibroids in pregnancy. So if you can look at, this is a very rough, the estimate. All right. But when we will go through ourselves, so maybe we will find another important topic, which maybe I have never studied, but you as a candidate think that, okay, no, I have to study this. Trust me, TOG articles are like a story. If you will start reading a story, so what you do? For me, I'm the kind of book reader. Okay, I do have my own small library as well. Okay, apart from my medical books and everything, one shelf is for that, and one shelf is for extra curricular, or you can say that the out of medical the books. So I do have literature books, I do have stories in so many languages because I'm a multilingual person. So, what I do is if I start reading one story, so I won't, they do anything until I finish that, the story. Same goes for TOG article. So please think that I am reading a story. Okay. Keep, your life interesting as well. At the same time, they don't be like, upset. No, 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 I have to do this. I have to do this. I'm not going to do that. Ease out your neurons. Okay, start your the TOG article roughly. Even if you are a slow reader, even if you are a very very the, I'm sorry to say, turtle kind of thing, this one TOG article has to be finished in hardly 1 hour at least, if you are a good reader and if you are studying the with proper focus. So roughly it will take 25 to 30 minutes, not more than that. So don't you think that you can take at least 25 to 30, or say 1 hour, dedicated hour in one day, even if you are covering one module? And if you think that you have been given a task that you have to do headache in pregnancy TOG article today, so don't you think that you can give at least one dedicated hour to understand headache in pregnancy? I think it is pretty doable. Okay, so if you will just start thinking of, oh my god, how to study, I am getting headache. Yes, headache in pregnancy itself is a very big headache, and candidates of part 2 know this because couple of the important questions comes in exam out of that TOG article. But what? We have to study. Okay, we can't just leave it as such because I'm having headache, I'm just like the kind of demotivated, I can't study, I don't want to study. No, 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 it's not going to help at all. At least try to stay focused, stay calm, stay motivated, and study. And I think if you really, from even today, if you really want to start your journey for part 2, I would suggest do read, for example, if somebody wants to take start from maternal medicine, do, the study 2-3 TOG articles in a day. Trust me, it's really going to make your life easy. Okay, because hardly and roughly it takes the 25 to 30 or maximum 1 hour, not more than that. And don't get stuck on one the topic. This is another the drawback of this the whole curriculum, because candidates think that because I did not study today's topic, so I'm not going to study tomorrow's topic. All right, so this way what will happen is you haven't finished today's topic, you are going to be left with tomorrow's topic, and then when you are going to start your third, fourth day topic, you will be having a huge backlog. For example, I was so busy today. Okay, I was in the hospital because labor room was so busy. Okay, if at all I was a student like you, and if I had to study one topic and I could not study that, so what I will do is, I'm telling you, because I can only give my example how I used to study. Okay, because that is very the I must say applicable and very clinical clinically applicable as well, because all of us are the working and the simultaneously doing multiple tasks as well. So if I haven't studied today topic, so I won't be like crying for another few days that I didn't study today's topic. I will move on, I will jump to tomorrow's topic, and then if meanwhile, if any day is relaxed for me, I will try to cover this today's backlog on that day. All right, and this is what a major mistake the candidates do it. Okay, yeah, almost all of them are in Telegram group. Okay, everything is freely shared. Even if something is not shared, you guys can ask. Okay, help is available. Like I said yesterday, I think to some of my candidates, that help is available on the all the groups. All you need to do is carefully use the all social media groups. How you utilize your the skills of googling, skills of searching. Use search bar in every group. You will find each and everything. All right, even if not, okay, ask for help. Ask for help. We do have the very, very good candidates all around the globe. Okay, even you can ask us, even you can ask med exam team. So we do try to send whatever is feasible, whatever is possible. At the moment we are running the WhatsApp group, and the our moderator Dr. Shiba, she always shares every topic one day before. Even in our course, when we are teaching to our candidates, we do share almost all material when we are starting our the 1 mini schedule. Okay, so again, help is everywhere. Please learn how to say, can you please give me this, can you please help me in this. So try to the ask. Nobody is going to help you if you are just going to be quiet and like this. Okay, so talk article, like I said, you have to read it like a story. You need to note down important points. You have to focus again on tables and algorithms. Mostly single best answers will come from talk articles. Okay, single best answers. So because talks are very the clear and the very to the point, and of course single best answers can be covered by that. Okay, what to start new one. And
Ma'am, can you show the back slide?
Even if in the coming days, if you think that your one day is very relaxed, so you can cover today's backlog. Okay, but don't get stuck on one topic. Because I haven't studied today, I'm not going to study till I cover this day, this topic. This is a major mistake candidates do. Okay, don't do that. Don't do that. All right, Mavish, very good. Okay, done reading this. Okay, when you do single best answers and extended match question, please, for God's sake, don't ask for key. Utilize your neurons. Where this question has come, what could be the reason for this question, why they have made this question, why I have to the answer, why I have to the kind of exclude all the topics. Okay, then you have to look for the particular best answers. If you are not going to utilize, and if you are not going to rehearse in your own mind that why and what and the where and the who, I'm sure everybody knows all these basic the what you can say components of learning, isn't it? Human learning. So if you don't utilize your own the studies or your own the knowledge, and all the time you are just going to look for keys, this is another drawback. Okay, this is another drawback. What you need to do as an exam candidate is discuss, raise your concerns, raise your questions, discuss amongst yourself. If you guys are in a group, okay, discuss amongst yourself. If you feel that still you are stuck at somewhere, okay, call for help. Call for help. I'm sure everybody knows because we all are obstetrician, isn't it? More or less. Okay. So call for help. Ask. If you are in a group, ask any other senior or ask any mentor if somebody is there. So eventually, with the passage of time, or maybe, when they will get a notification, they will answer, isn't it? Archived mean that they have been removed. You don't have to study them. Which have been removed from MRCOG website or any other website, you don't have to study them. Okay. Question practice is must, like I said. And you guys can take picture of this important slide. And, these are the books which you have to cover. When I say books you have to cover, it means you have to practice. And again, there is no hard and fast rule that the same questions will repeat in your exam. That is not possible at all. Okay. And don't always think of, this, that you have to study. You have to cover everything from 2023. Okay. Andrew Sizer, it has got single best answers, extended match question. You do have Rekha Butankar. You have to do single best answers part. Justin Kune, this is a list for single best answers. Okay. Brian Magawan, Amanda Jones, Seema Sharma, Janish Gupta, Succeeding, Tahir Mahmood. Okay, hold on. All these books are old, you can say edition. 2018 edition, perhaps 2015 or 16 edition. This is 2020 edition. This is even more old. Okay, so what kind of challenges you can see in these questions? Keys can be wrong. So you don't have to make any kind of fuss on any key. Okay, utilize your knowledge, study, open guideline. Okay, if you don't remember, and answer according to new guideline. Maybe some of the recommendations have been changed. Maybe few guidelines have been archived or changed or anything. Okay, got it? So eventually you have to correct keys. Again, these are for your practice, just to make you, the capable of solving single best answers and extended match questions. There is no guarantee that all these questions can come in exam. Okay, don't think like that. All right, single best answers. Then again, the EMQs. Tahir Mahmood is important, and Sizer, P. Sinha, Prabha Sinha, both EMQs book. One is for gynecology and the other is for obstetrics part. Very beautiful book. But what you need to do, you have to do questions. You don't have to follow keys because we don't have any other sources to cover, anything from. All right, we can't practice from any local book or any other book because we have to follow standard. So almost all these books are standardized MRCOG pattern book. So what you need to do is you have to practice as many as questions as possible. All right. So what it is going to make you? It is going to make you a good, competitive, compatible candidate when you will enter into your own exam. All right. Rekha Butankar, Kalaivani, Andrea Pilkington, Succeeding, Justin Kune. This is a very beautiful book, bit tough, but good. Okay. So you can cover, again, be very mindful with the keys because keys can be according to the old guidelines. All right. So you have to replace or you have to bring your own keys as well. But you have to do all quality questions from all these recommended books. You can see, we have got 9 or 10 books, isn't it? So what exactly do you think is going to give you another extra anything out of, all these books? If you practice all these questions one by one, so don't you think it's going to be helpful? It is going to be helpful. Okay. And if you are going to be very thorough that how to, do thought processing for one question, especially for extended match questions, then I'm sure exam is going to be easy as well, relatively easy as well. All right. So be extremely careful that these all are, in fact, the practice books. There is no guarantee and it cannot be possible that all these questions will come in exam. This is for you, for any exam candidate to just practice, to just, be thorough with the practice of extended match questions and single best answers. Okay, clear everyone? all these are important. Everything is important. Okay. Don't ever think that I have to do 2 things. Please tell me 2 important things. I would suggest, solve as many questions as possible. But all those questions should be, and, the very standardized. It should not be from any of your, the local exam or anything, because every country has different protocol. Okay, every country has different pattern. So if you are from Pakistan or India or any other country, so please don't do your local books. Always do MRCOG pattern book. Okay, so that is only going to help you guys. Then, out of these 9-10 books, if you really think that, you have to do, the any online questions as well, so you can take strategy e-learning subscription, or still if you think, no, I have to do more, so you can take Pass MRCOG subscription as well. Both are online. Don't rely on any hard copies available. Okay, mind it. The strategy cannot be in hard copy at all. If anybody is doing that, that is very bad and that is forbidden. Okay. Pass MRCOG again, I think they are cheap and they have got, the couple of packages, subscription. So if you guys go to www.passmrcog.com, so you will get, the whole list of packages, whichever you want to take, you can take according to your own feasibility. Okay. So strategy is very important. Strategy means it has got, the 97 tutorials. You can be MRCOG associate. You can buy those, the tutorials, and it has got theory as well as questions as well. So before every topic, they will have pre-assessment of that topic and post-assessment of that topic. So if you do, all those assessments or the questions, I must say, so this is going to be very, the good for you. Eventually, you have to rehearse. You have to just, the practice as many questions as possible. Again, don't think that is this, the must to do, or this is, the eventually is going to come in exam. No. Remember, this is just for you, for your practice only. Clear this thing, because even just today I got a message from one candidate that, okay, if I do these e-learning, subscription, so I am surely going to pass. I'm sorry, nobody can guarantee, the success in exam. Okay, but we always encourage and we always recommend to solve as many questions as possible, because that is the only way to have a good grip for exam. Otherwise, we will be lost, of course. Okay, and nothing can be, kind of hard and fast, and nothing can be very the kind of thing that, okay, no, I have to put emphasis on this, I have to put emphasis on this. Okay, clear this part? So be very open-minded when you are starting your preparation. Okay, when you are into this MRCOG journey, be very, the open-minded, and be ready to take every challenge as well, because every day, maybe, the today or tomorrow, you will get a new guideline. Maybe, you will get another, the revised part of any other guideline. You got my point. So be ready for every challenge. And when you are going to be ready, and be ready, I'm telling you, be ready, because we may get, because the medical field is evolving. So we are going to have, the so many, the new guidelines, TOG articles as well. Okay. The current, like I said, Habiba, the current miscarriage, this 27 June 2023. All right. So this is going to be evolving. So don't just fix your mind all the time. No, I have to do this. I have to do this. I have to do this. All right. Okay. Now general strategy. Everybody loves to talk how to pass an exam. I love to talk, how candidates fail in exam, because we have to overcome that, isn't it? Lack of confidence, overconfidence, following too many advices. I'm talking to Dr. Zaib, I'm talking to Dr. ABC, I'm talking to Dr. So and so and so. By the end, I'm lost. I don't know what to follow. I don't know what to do. And then, I cannot do that. I cannot do that. And the third and very dangerous, the thinking is overconfident. Oh my God, this is just a piece of cake for me. I can do it like this. I can do it like this. Following too many sources for one topic. I have to study one topic, but I'm looking for, no, I'll be master of this topic. And I will do from strategy, I will do it from guideline, I will do it from TOG article. All right? No. This is also another, the bad approach towards exam. Following so many or almost every single group on social media. I'm active on WhatsApp, I'm active on Facebook, I'm active on Telegram. And on Telegram, we do have thousands of groups. WhatsApp, we do have thousands of groups, and so for Facebook. There is no harm. Again, there is no harm because knowledge is everywhere. I always say knowledge is everywhere. This is you who have to utilize what I have to, the get, why I have to, the which group is going to be helpful for me, which group is going to be useful for me. I'm not going to be sitting on my, the chair all the time, or, the lying on my bed all the time and scanning, the messages. I will get strain. I will get eye strain. I will get headache. I may be lost. I may be frustrated. Okay, come on, log out. I can't study. Wi-Fi close, data close. I can't study because, I'm a bad student. Don't do that again. Okay. Just try to limit yourself, because all of us, like I said earlier, we all are working, we do have family to take care of, we do have to do so many things on daily basis, isn't it? So reserve your energies. Okay. And plus, at the same time, you have to take care of your health as well, because I know, my July batch, we have been doing practice in the end for the 1 month with me. So, the one candidate, I literally felt for her, they felt for her that day. She said, I'm having headache because I'm having constant eye strain. Okay. So because we all of us, can have this part because we are using a lot of social media, isn't it? So at the same time, you need to be very gentle on yourself as well. You need to take care of your health as well. And at the same time, you have to limit your energy. You have to limit your, the kind of surfing and searching and, the commenting and being active everywhere. No, it's not going to help again. Okay. So I'm again, please, don't take me wrong in this part. That can be helpful in a way, but that can be, the kind of very stressful in a way as well. Okay, that particular group is so active, that so and so is studying so hard. I'm not studying. I'm not a good candidate. Oh my God, I'm bad. Dr. Zaib, I'm leaving this exam. Dr. Zaib, I cannot do this. Can you just imagine, we can't be like this all the time, isn't it? We can't compare our life to, anyone else's life. The other day, I guess, last week when we met. So like I always say that, we can't compare our life to anyone else's life. You can't fit in my shoes, I can't fit in your shoes, isn't it? I don't know what life are you hailing at the moment, how good, how happy, how stressful, or how stressed you are at the moment. You don't know how I was whole day. I'm smiling at the moment, but my whole day was so stressful. Okay. So nobody can fit in anyone's shoes. So stop comparing yourself with anyone at all. Another golden rule. Stop comparing yourself. Okay. Yeah, sure, Mala. Sure, I will. Okay. So please stop comparing, number one. All right. And stop or I must say limit your energy, because we do have hardly, the 4 months for January exam, and now exam is going to be just for January and, the July diet. So you can imagine that if you don't give your 100% for January exam, you will have to wait for another, the 1 year, complete 1 year. And who knows, by the end of 1 year, you will get more, the guidelines, you will get more, eventually you will get dog articles. Okay. But you will get more guidelines. So get over with it, give your 100%. Okay. Be your 100%, be the best version of yourself again. Okay. Even if you have lost, your exam with, the 1 2 3 or say, and this was a very, the kind of tough result this time, which we have, the observed in last recent years. Okay. So make sure that you are, the utilizing your every day, every second. Okay. For, this exam. Least time needed for studying part two. Well, depends on your circumstances, depends on how much time you can give. Okay. But roughly 4 to 5 months studies is enough. Nobody can studies for ages, because part two is like, I mean, exhausting, isn't it? So I would suggest and I would advise that, the rather studying for years and years, sorry, Yes, 4 to 5 months is enough. Okay. Yeah, I'm okay. Thank you. Thank you for asking. Actually, I'm talking, and I had a very stressful day, like I've told you, very busy labor ward and very unusual cases. Eventually, I have to deal with. So yeah, kind of tired and kind of, the that's okay. That's okay. 6 months is more than enough. Whoever are you, dear M. 6 months is more than enough. 4 to 5 months is enough. Okay. Then this is a very, the beautiful picture and plan ahead. Okay, study hard, smart, and the general advices. Organize yourself, like I said earlier. Make your folders of all modules on desktop, like the laptop, iPad, MacBook. Even if you can, they get them printed, you can get them printed as well. All right. Good grip on salient points. Discuss. Don't look for key. Don't wait for key. Sometimes what happens is that really, I get frustrated. Why, we have to give key, we have to look for. Okay. Whenever you think that you have any confusion, syllabus, you have your guideline, Google, just search, give your answer. Like I said earlier, be the best version of yourself. If this particular thing you never knew before, but in today's, the date, you know it better. So you can be good, isn't it? So give your reference. Okay, look, we are studying together, the 4 or 5 people, or maybe, the group of, the course people. So I do have a, the confusion in this. So when candidate will, they quickly um, search and can send, the reference that look, this is written in green top guideline, and look, this is written in tog article. Okay. And this really helps. If you will fight for key, if you will look for the reference yourself, and if you will discuss amongst your own colleagues, fellow colleagues, this is really going to help you at, a lot. All right. And if you really want to make your own notes, you can do that. If you don't want to do that, because everybody has a different pattern to study. Okay. So you can't follow, the whatever I say, or you can't do whatever I tell you to do. But of course, you can follow what is good for you to, do it. So be positive all the time. Okay. And you have to absorb, whatever you study with the help of examples, references, and reasoning. And how do we, they learn? If I correlate, whatever I'm studying today, for example, I have dealt with one very important, the cardiac disease in pregnancy with the labor. So if I will correlate with my cardiac infarction or so and so, yeah, this is going to give me a very good idea that, okay, this topic can be dealt like this in terms of, in the lines of guideline, in the lines of recommended sources. So if you will, the give reference, if you will learn with the help of examples, yeah, I have seen this case when I was doing my PG training. I have seen this case when I was in that particular setting or clinic or hospital. Okay. So try to correlate things. This is really going to, give you a positive impact. So for us, the med exam expert team, so we do are into, we are into one, the course for MRCOG Part 2 January 2024. And, we do have a very, the dedicated schedule, very dedicated preparation study. And we do have, the so many things, on the med exam expert website. So we do have live sessions. And of course, I'll be there as a mentor. And if you miss any session, you can have recording, and this is going to be with you throughout your, till you pass or till you have your exam. Okay. You will have, the each module test, you will have summaries. Those are going to be updated till 2023. You will have mock exam. You will have a dedicated study room with me and with my, the team. And of course, you will have psychological support as well. You guys can see that I can speak a lot, and I do speak a lot as well. Okay. So all the time, and and students, who have been with me throughout in my, last 4 to 5 years of teaching career, so they know me, that we do crack jokes as well, we do laugh, and we do cry, we do study as well all the time. Okay. Thank you so much, Baba. Thank you so much. Means a lot. Okay. But again, see, even though I'm taking course, but I would again suggest you don't have to completely rely on me or any other source which is given to you. You have to read yourself thoroughly once, at least. You have to go through once. At least you should know that what exactly is there, which topic, which thing, which talk article, which guideline. Otherwise, if you really think that you have very compact schedule and you can't even open anything, then yes, MedExam website is there. Okay. And our whole team is very dedicated. We almost, they help 24/7, apart from when we are sleeping. Of course, we are also human being. After, apart from that, we do try to help, all the time. Okay. So for the January exam, we will be there. So me, myself, Dr. Hassan will be there, and Dr. Rupam will be there as well. Okay. Thank you. Means a lot. Means a lot. Okay. So I just have given you my introduction. So yes, I'm there and I'm in front of you. I'm, very easily approachable. Okay. Very easily, you can say, the you can easily talk to me anytime. Okay, you can text me, you can ask any help. I do try to help as well. Okay, because by from the till date, I have learned how to do multitasking. So even if I'm in the labor ward, even if I'm the doing round, even if I'm the doing clinic, whenever I open my mobile, I do try to the answer. But otherwise, if there is any lag, if there is anything, eventually I will come back to you. Okay, I'll be at your service. All right. So this is for, the current course, which we are running. And we just had 2 sessions. One was with Dr. Muhammad Hassan, urogynecology. The other was with Dr. Rupam. And, the all maternal medicine candidates who know me, they know that I love maternal medicine. I love teaching maternal medicine. And of course, when you love something, you teach effectively. And of course, you do it effectively. Let me read the messages. Are the guidelines updated? Oh yeah, it is updated. It is updated. iPhone, ma'am, like there are some topics which have very confusing or say long guidelines. For that, we can go through summaries as we have a very hectic duty, and other than duty, many of other things happening, and going through whole guideline is possible. You can see, you have to tailor your own study pattern yourself. Okay. So I won't say that, you just have to, the say or do whatever I say. Okay. You have to tailor your own preparation yourself. All right. You got my point? Cesarean section is updated and there is no much update. Okay. Yes, you can read from MedExam expert website as well. But again, I would say not, but summaries are enough. I don't know what exactly do you want to say, but they are okay to read. They are okay to go through. Okay. Okay, fine. So for every module, we have a very dedicated, the mini schedule from one online session to the other online session. And we do give important topics according to that module. Okay. And our candidates, the read it themselves, and then they study with Dr. Rupam, they discuss it, and then again they repeat it in the online session. So this way, they are going to be very thorough. Okay, they are going to be very thorough in the the module, and then they are going to be very thorough in their the studies of that particular module as well. Okay, so this is how we they go for our course, and in the end we do go for revision. We look at the many things the very differently. We do revise, and my candidates know me that we had a very good bonding, in especially last that month, when I was with them. I was studying with them, and we had very good the kind of discussion almost every day close to exam. Okay. PDF of recording session, what do you want from PDF? PDF is for me. So do you really think that, I can give you my, the notes? Okay. Please don't look for that. Again, you are going in wrong direction again. Don't look for shortcuts. Okay. We have already given you plenty of shortcut, and now you really want my brain. Okay. You have to read all. Okay. For January exam, you have to study all. 2023. So utilize your neurons wisely. Utilize your neurons wisely. All right. So this was all about part 2 preparation and all. And I'm so sorry. 1 hour has been elapsed. Mhm. Okay. Any questions so far from part 2 preparation and anything? Hmm? Any question? Khulud, any question? Anita, Michelle, Hanadil, and I can see so many names. Habiba, Hisham, Lisa, Lena, Mahvish, another Mahvish, and iPhone, Vijayalakshmi, Huma, and everyone. Okay, your recommendations. Issue 1, issue 2. I have told you that you have to study. Okay, all talk articles means at least you now you have to know that what you have to study. Okay, important ones. Mala, let me ask someone to assist you. Aisha, are you there? Please help this candidate. Aisha, Anam, Sabah. Hmm? Please help. Okay, okay. Very good, Ibtisam. Very good. No discussion of two talks mentioned today. Were you here for only talk articles? Okay. So I presume there is no question. Mhm. So everybody is clear regarding that how you are going to be in this exam. I need to save your emotional supporting sessions for times when I know that. I know though. I know that, Lena. Okay. I know where are you coming from. Okay. So don't worry, don't worry. I'll be there and you know that I'm with you. Okay. Till you become MRCOG. So don't worry about that. I'm not going to leave you. You're not going to leave me. So yeah, hang in there. Yeah. Okay. So let's get started with our first important talk article. And then if time allows, we will cover second, or otherwise I will schedule another session. Okay. Promise us that you will give this booster dose to I'm with you. You know that sometimes students, they do complain about me to med exam as well. Let me tell you this too. Dr. Zaib is so strict. Dr. Zaib is so strict. She all the times, she always say, don't ask for key, don't ask for key, study. Seriously, you know, you have to be strict. Okay. At the same time, when I am, the tutoring or when I am working as a teacher. So what a teacher does, teacher gives you support, teacher gives you hand, and the teacher gives you, the tips as well. At the same time, teacher scolds you as well. Okay, isn't it? So it doesn't mean that, I'm being strict or I'm being bad. It means I'm being helpful. It means I'm very much, the sincere that I really want to guide you in a very best possible way. No need. Part 2 is very much, the theoretical. All right. So whatever clinical need is going to be important or very much is going to be there. So we are going to help you. All right. So don't worry about that. Okay, Aisha and Maria, no problem. You are missing my previous lecture. I wish I can, help you more. But inshallah, I will try to arrange so many sessions. Maybe we are going to meet every fortnightly with, the talk article discussion. So don't worry about it. Okay. You are going to see me 1-to-1. Yeah. Oh, Mara, my girl. Thank you. Thank you. Thank you so much. Okay. So now let's do this acute coronary syndrome, and for tuberculosis I will schedule another session. Okay, that's my promise. Hopefully after a week or so. Okay. So yeah, acute coronary syndrome in pregnancy. So anyone has any idea what exactly it is? Acute coronary syndrome. How do you perceive in your mind? What exactly comes in your mind when you see this? Acute coronary syndromes in pregnancy. Heart diseases, yeah. Acute coronary, when it comes to small, the arteries of the heart, okay, intrinsic blood supply of the heart, isn't it? So this is a very new talk article which published which got published in April 2023. Very good, Kamal, Mariam. Yeah, myocardial infarction. Myocardial infarction. And we had, I think, 2013 or 14 myocardial infarction talk. And I was very happy when I saw this talk article. Okay. This is very good. And it has very new information as well. Okay. New information as well. So we are going to discuss in depth. So acute coronary syndrome. Okay, now because we are discussing TOG, now let me tell you how you are going to read TOG article as well. So when we read TOG articles, first of all, what we do, we are going to look at that what exactly is the opening statement. Okay, so they say that the rate of maternal acute coronary syndrome is reported between 0.6 to 10 per 100,000 pregnancies worldwide. I got 1 point for my notes. So I will write it down at when I'm going to make my own notes, or maybe I'm going to jot down important points. So I'm going to, okay, hold on. Let me. Is it visible now? Mariam? Okay, Lina, very good. I'm sorry. Okay. All right. Brilliant. So the first line, which I'm going to look at is, because I'm reading story, and I have to start my story from the scratch. Where it came from, what is its, the etiology, physiology, and how it is going to be managed, and then how it is going to be particularly managed in pregnancy. What are going to be the complications? Because I'm talking about pregnancy, so I have to look for mother, I have to look for baby as well. I'll be, the dividing my studies into two parts: effect on mother, effect on baby. So I'll be looking, see, this is the outline when I'm going to study this talk article. So this is going to be my outline for this talk article. So I won't be overwhelmed about, what I have to focus on. Okay. Okay, Mariam, thank you. So the incidence is 6.2 per 100,000 delivery. Another important exam point, with a mortality between 5.1 to 11%, which is quite high, because the last 2 or 3 MB-RACE report, I'm sure everybody knows, direct cause of maternal death has all been, it's been there, I think, for 2 to 3, the MB-RACE reports, cardiac diseases. Okay. So cardiac diseases or cardiovascular disease was the leading cause of maternal deaths, which was accounting for 17% of all maternal death. Out of them, ischemic heart disease was responsible for around 1/5 of the cases. 1/5, too much. We are talking about ischemic heart disease. Okay. When there is a blockage in the coronary arteries, okay, microcirculation, microvasculature, so it is going to cause ischemia, and later on, the other things as well. So pregnant women, because of the change in the human physiology and all, pregnant women are 3 to 4 times more likely to suffer from acute coronary syndrome than age-matched non-pregnant women. And the incidence in this population is rising. And the factors can be, so many. It is basically multifactorial. Okay, so the risk factors for acute coronary syndrome can be categorized according to the underlying pathophysiology. So now, pregnancy-associated spontaneous coronary artery dissection. You are going to see, again, this is also beauty of part 2, that you are going to see so many, the mnemonics, so many, you can say that abbreviations. Okay, so you need to be very, very quick and very, the clever to pick all those abbreviations. Okay, so PASCAD, pregnancy-associated spontaneous coronary artery dissection, occurs more commonly in women with connective tissue disorders such as Marfan syndrome, hypertension, family history of spontaneous coronary artery dissection, SCAD. Okay, so the risk factors of atheroma, because we are talking about ischemia. So how ischemia will happen? There is a vessel. Once there is going to be any embolism, okay, it will cause, any kind of blockage. Whenever there is going to be any blockage, there is going to be ischemia. Blood supply will not go farther than, from that blockage. Okay, so there is going to be, the atheroma. Atheroma means any plaque, any, the thrombus which is lodging. So what are the risk factors for atheromatous diseases? Maternal age, obesity, smoking, diabetes, hypertension, dyslipidemia, and family or personal history of ischemic heart disease. See, I'm reading a story. Is it making sense now? Is it making sense? I have, first of all, collected worldwide incidence, then pregnant population incidence. Then I have learned that why it is increasing in, pregnancy, because of the D range, because of the, the underlying pathophysiology. Then I have learned that, okay, what are the risk factors for any atheroma, any ischemia? Isn't it? Maria, is it clear to you? Habiba? Hmm? So, maternal age, obesity, smoking, diabetes, hypertension, dyslipidemia, family or personal history of IST. Makes sense, isn't it? So, all these risk factors will superimpose any pregnant woman to have coronary artery heart disease. Okay? Brilliant. Brilliant. Okay, now follow with me. And after this, the half an hour rehearsal, trust me, this is going to be at least 50% in your mind. If you will rehearse with the same in your the practice, when you will read talk article yourself, trust me, this is going to be easy. Okay, so read it as a story. Okay, all right. Now I know, other than pregnancy itself, factors which increases the thrombotic risk are thrombophilia, hypertensive disorders, transfusion, infection, multiparity, sickle cell disease. Making sense? Yeah, because I am thought processing everything into acute coronary syndrome. And now comes exam question, because we are dealing with pregnancy. Acute coronary syndrome is significantly more common in third trimester than at earlier gestations. Yeah, so in addition to representing increased thrombosis risk associated with anemia, blood transfusion is probably a surrogate marker of ergometry use, which may be more associated with spasm than either of the other etiology. So that's why generally ergometry is not to be used, or you can say it is contraindicated to be used in the third stage of labor, in hypertensive disorders, in your the cardiac disorders as well. Okay, because it will increase marked the ischemia, marked spasm, which may lead to more acute coronary spasm and acute the MI in the postpartum period as well. So ACS, we are going to use this ACS all the time because we're talking acute coronary syndrome. It may occur at any gestation, but in one study, and it has been a large randomized, the study, 73% of the cases occur during pregnancy and 27% in the postpartum phase. And study have found that 38% have been occurred antenatally, 21% intrapartum. Can you imagine? Because after delivery of the placenta, at least 1 liter of the blood is pooling back towards heart from the uteroplacental circulation. If heart is already weak, so what will happen? That back pulling of that blood will cause, a lot of stress to the laboring mother. Okay, isn't it? So it will cause more, the ischemic events. So 21% around intrapartum and 41% postnatal. Huge. That's why ischemic heart disease has itself got at least 1/5 proportion of the cardiovascular mortality. Now, what is the pathophysiology? We do see pathophysiology has been changed in the cardiovascular system in pregnancy, right? Because of progesterone hormone, pregnancy hormone, isn't it? So across pregnancy, a rapidly changing maternal physiology stresses the cardiovascular system. This includes a blood volume increase of 50%, part one question. I'm sure everybody knows that. And within another extra increase in cardiac output, 50% physiology. Now you can imagine that if heart is already weak, and with the presence of pregnancy, already 50% increase in cardiac output and blood volume as well. If already there is any pathology running, so a pregnant woman will be in danger, isn't it? So what will happen? This in turn will increase in basal heart rate, and women often become anemic secondary to dilution because physiological anemia is there. And what is the most common and most, the time of physiological anemia? 32 weeks. Okay. So that's why we always repeat hemoglobin at 32 weeks as well in the last trimester. Yeah. So what will happen? Iron deficiency, blood pressure, peripheral vascular resistance will fluctuate. Pregnancy is a prothrombotic state itself, because thromboembolism risk is high throughout pregnancy and even more so in postpartum period. So the woman connective tissue weakens and stretches in preparation for birth because body has to accommodate birth. And this includes the vasculature as well. So when there is going to be, the very any mishap in demand and supply, so it will cause more stress on the maternal cardiovascular system. Okay, so usually it will lead to myocardial ischemia. We divide ACS into three groups on the basis of electrocardiogram. Sometimes we call them as EKG, sometimes we call them as ECG, so it's all fine. All right. So on the basis of ECG, we will do what? We will make a subgroups. We will do ST elevation myocardial infarction, non-ST elevation myocardial infarction, and unstable angina. STMI, non-STMI. Okay. So now I have learned that why myocardial ischemia occur in pregnancy. What are the risk factors? Now I will divide and now I will read one by one, and then I will see what is the management of STMI, what is the management of NSTMI, what is the management of UA. If I will make my, the concept from here, it is going to be very easy that I will complete my story in given time. Okay, so let's see. STEMI, it is the ST elevation of new left bundle branch block on ECG within a clinical context that follow fit with acute coronary syndrome. And how patient will present? Chest pain, shortness of breath, ventricular arrhythmia. There is often dynamic instability as well. Patient may have, the low blood pressure, high blood pressure as well. So this can be the strongest predictor in the outcome of treatment as well. So national targets focus around a 1 hour window between ECG diagnosis and restoration of coronary flow. See, 1 hour. If we won't restore in 1 hour myocardial function in 1 hour, we may have, of course, infarction, and then, of course, the post myocardial infarction changes in ECG. Because the cardiac myocardium is rich in blood supply. If something is not going, I'm sure everybody knows, what exactly is the basis of ECG, what are going to be the changes in ECG in pregnancy, all right, and how we are going to, see that this is the physiological changes in pregnancy or pathological changes in pregnancy. However, this ST elevation, because I'm sure everybody know that we have got P, Q, R, S, T, okay, P, Q, R, S, and T. So if it is going to be elevated, so this is going to be in pregnancy and non-pregnancy state both. Okay, so plus, the heart has got walls, anterior wall, posterior wall, anterolateral wall, central wall, okay, and apex. So the ECG leads are going to be designed, and they are going to be give us, the overview that which wall is affected. All right. For example, if we talk about, the left 2 lead, long lead 2, long lead 3, and AVF, 2, 3 AVF, inferior wall MI. Okay, it is going to be inferior wall MI. If it is going to be anterior, it is all going to be chest leads, V1, 2, V6. If it is going to be lateral, it is going to be 1 AVL. Okay, so I think this is the basic, and the candidates who have just entered from part 1 to part 2. So, and plus this is basic, even if we are OBG, but at least we have to have this basic, the knowledge of ECG. Okay, so 1 hour is mandatory from the diagnosis to the restoration of coronary flow. If you don't do that, that part of the heart is going to be dead. That is going to be ischemic, necrotic later on. Okay, so yes, in the dead area, when there is not going to be any current flow, so we will eventually get Q waves. P, Q, R, S, T, okay, U, V, Q, we will get Q waves. Okay, this is ST, now see ST elevation MI. This is going to be very clear, ST elevation. Then we will have non-ST elevation MI. Earlier, they used to say ST depression. Okay, now they say, now in this talk article, they are saying non-ST elevation, NSTMI. So it's a more stable clinical situation, though hemodynamic instability is not that uncommon. Risk assessment on an individualized basis is crucial to satisfy the patient who would benefit from an emergency procedure against the procedural delay or conservative management. ECG changes may include ST depression and T wave inversion, although ECG can be normal as well. Cardiac biomarkers are raised because whenever there is going to be breakdown in muscles, what will happen? Muscles will have proteins and proteins will start rising. So we call them as cardiac biomarkers. Okay. So the third group is unstable angina. As name says, unstable. And angina, of course, it is going to be pain. So chest pain, shortness of breath at rest, sometimes with the same ECG changes as NSTMI, but without any biomarker rise. Now, be extremely careful because all these points can come in EMQ. And then they can ask you, okay, see, now you can see cardiac biomarkers are raised, cardiac biomarkers are not raised. Symptoms are same. You got my point? Symptoms are same. ECG changes are same. ECG changes may not be there. All right. But stable angina typically presents as chest pain or shortness of breath that is relieved at rest. That's why it is termed as stable, because it is going to be relieved. Okay. It is going to be relieved with no biomarker rise and in most cases a normal ECG. See, so many differentiating points. ST elevation. All right. Non-ST elevation. Cardio biomarkers are raised. Unstable angina, same as NSTMI, biomarkers are not raised. Stable angina, because the pain will be relieved at rest. Patient can have normal ECG as well, because patient will just have constriction. And once patient will be like, in the stable position, taking rest, the pain can subside. All right, making sense? 3 types. Are we good to go? All right. Now, in pregnancy, different etiologies will the count. Okay. So sometimes what we have to do is that we need to look at, what is the subgroup. So one study has found to be the underlying cause in 27% of cases and 43% in older studies. So this is a subgroup of whole population of, the coronary artery, stable coronary artery disease. Okay, so pregnancy associated, the spontaneous coronary artery disease usually occurs in the late 3rd trimester and in the early postpartum period. Another differentiating point for exam, isn't it? They can ask you. So the pathogenesis is not fully understood, but this timely suggests an association with an increase in hemodynamic stress and fragility of the vasculature across the period. So why this ischemia is happening? We have just said that, okay, atherosclerosis. If the vessel has any, the atherosclerosis, hyperlipidemia that has led to this. So has now overtaken PASCAD, pregnancy-associated spontaneous coronary artery disease, are the most prevalent etiology. Important exam scenario. This has come in my exam. That atherosclerosis is, the most common etiopathology. Probably because of the rising maternal age, because we are talking about UK. And these days, and in the last couple of years, this has been a trend that women are delaying pregnancy. So of course, once they are going to be in the, the elder age group, so they will have, the age-related changes in the vessels as well. All right. So if at all they do have any other comorbidity, so yeah, things are going to be added up. So 39% of ACS in pregnancy were associated with atherosclerosis. This is pretty high. So mind it. Another exam point, according to me. If at all I have to make my own points, so I will be jotting down all these points for myself to revise later on. Okay, so thrombosis and thromboembolism within otherwise normal coronary vessels accounts for 10 to 20% of cases. Plus, later on, see, atherosclerosis, thrombosis, coronary artery spasm. Spasm will be seen in only 2% of cases because I am just figuring it out that what exactly is happening with this, acute coronary syndrome. So what is the etiopathology? Etiopathology is atherosclerosis, thrombosis, coronary artery spasm. Spasm is just 2%. Thromboembolism, thrombosis 10 to 20%. And, the atherosclerosis, almost 39%. You can, 40%. You can make it 40% for the, sake of memorization. Then how patient will present in pregnancy? Important, isn't it? So ACS usually presents similarly in pregnant women and age-matched women in the non-pregnant population. I am 35, I'm pregnant today, and the other patient is 35 and she is non-pregnant. but the symptoms of ACS are going to be similar in both. Okay. However, atypical symptoms are more common in both subgroups. Anything can happen anytime. So be extremely vigilant. But some of the important symptoms are going to be there. Chest epigastric pain that may radiate to the neck or arm are typical symptoms of ACS. Okay. And the atypical symptoms can be non-specific pain anywhere in the body, nausea, vomiting, back pain. Now think of, have you ever seen any ACS patient in your clinical life? If you have seen, try to correlate. Oh my God, okay, that patient that day came with these type of complaints. Yeah. If you will correlate, your life will be easy. You're managing a myocardial infarction patient yourself. Okay. So this is how we have to, the study for part 2. Reasoning, give reasoning, give justification, look for reference, and then, try to correlate things. There may also be dyspnea, hyperhidrosis, agitation. It is crucial to be aware of cognitive diagnostic bias when assessing pregnant women, as symptoms are often downplayed or dismissed on assessment. Patient is hyperventilating, and I'm saying, no, you are okay, because hyperventilation is normal phenomenon in pregnancy. Patient is having pain. Maybe, you are just exaggerating. Okay. Don't take now, trust me, in the last 6 months, I myself have diagnosed 2 acute MI patient in pregnancy. One was, I think, 28. I think I have told my candidates in July batch as well. One was, I think, 28, and one was 34. Okay, close to. And luckily, I got they got diagnosed and they were timely managed, and alhamdulillah, they had the successful outcome later on as well. Okay. So these things are very common. So never, if anyone say, please, always, they don't ignore. Always listen to patient. If patient is telling you that I'm having pain, doctor, in my chest, I'm having epigastric pain, and which is very unusual. So please, take that pain very seriously. Yeah, 2 patients in 6 months. And of course, sometimes if we will take epigastric pain as normal pregnancy heartburn or something, we may, the overlook this MI, isn't it? So always have an ECG as first biomarker to just exclude your myocardial infarction. Examination may be unremarkable. Vital signs may indicate hemodynamic instability. If it is PASCAD, thrombosis and spasm will represent in STMI or non-STMI. Only atheromatous disease may present as stable or unstable angina. So, exam lines, for me, this is very important. Rarely, women may present in cardiac arrest, very rarely, because mortality in cardiology, not cardiology, but in pregnant population, it is very much less if we diagnose and if we treat them timely. Okay. In this instance, patients should be managed as per maternal cardiac arrest guidelines, of course. So cardiac causes should be considered in all women presenting with cardiac arrest. Other causes of chest pain should be considered in the DD, including embolism, aortic dissection, pneumonia, GERD, musculoskeletal pain, and anxiety. Anything can happen, but never overlook stomach pain and chest pain in pregnancy at all. Okay. And if at all it is radiating to the neck or jaw or, the arm, so they take it very seriously. So how do you investigate? First of all, history examination. Very important. Talk to the patient. Listen to the patient. Okay. Don't take any complaint so lightly. Don't always be in your own zone that, okay, this could be this could be this. No. Patient is, your, you can say a book. Patient is your book. If patient is telling you, look, doctor, I'm having this problem. Okay, take that problem so seriously, because we have to take history, we have to do examination, and then let alone we can, decide for clinical diagnosis, and then we can confirm that diagnosis on the basis of, the certain laboratory parameters. All right. So history examination may raise the suspicion of ACS. Okay. Then, but diagnosis is often delayed. Specific investigation can provide greater clarity, left or right, any arm. Okay. Because the central part, if you will talk about the center or the anterolateral part of the heart, okay, it will go to the jaw, it will go to complete, this jawline, and, the any part of the heart or the arm as well, left or right. Because we generally think the heart is on left side, so the pain is going to be on left arm as well. Okay, which is not true, isn't it? Because I mean, the whole body is supplied by heart, isn't it? So any part of the body can be affected, but moreover, these are very important because the upper body is going to be directly supplied. All right. So of course, the anterolateral, if it is anterolateral MI, central MI, or any problem, so yeah, it can go to right arm as well. Okay. So don't just the fix your mind on that point. All right. So now we have to take the investigation. Okay. Till now, is story clear? How this is happening? What are going to be the causes? What are going to be the different types? And what are going to be the underlying risk factor for every type? Yes, yes, yes. ECG is must. Claire, Habiba, is it clear? Because you are following the pattern. Okay, Baba, Mariam, and Henrik, very good. Vijayalakshmi, and there is any other, I don't know, whoever is there. Okay, is it clear? Is it making sense? Is story is building in your mind that this is how you are going to see cardiac, the patient in pregnancy? Yeah. Gastric irritation, yeah, that's what I'm telling you, Aisha, that this is very important, that yes, we do overlook. That's why I'm telling you, if a patient is telling you again and again that, look, doctor, I'm having epigastric pain, don't overlook it. At least have baseline ECG. Because even if she is having any STE MI, ST depression MI, at least you will have an overview, at least. And if you know what are the normal findings in ECG, okay, which are normal findings in ECG, and if you will just look at the ECG, okay, and this is what I advise to my all candidates, because me myself has worked almost 1 year in cardiology, so I have I the wholeheartedly love cardiology, so at least I know the basic ABCD of ECG. But for you as an exam candidate, or even as a doctor as well, whenever you are free, go to any of the relative ward, medicine ward, cardiology ward, look at certain ACGs, okay? Try to understand the ABCD of ECG as well. All right. So trust me, this is going to be a very good additional piece of information as well, and yet useful too for your patients. Okay. ECG. We can do ECG, chest X-ray, biomarkers, echo, angiography, angioplasty, cardiac CT scan, cardiac MRI, CT, pulmonary angiogram, and ventilation perfusion scan. Can you just see how it is escalating from the very basic? Because ECG machine is almost available in even a very small unit. So can you just imagine that you can diagnose MI even if you are working in a very small, very low resource, the unit as well, hospital, clinic, or wherever, isn't it? So you will escalate. ECG baseline. If you see any changes in the ECG, okay, go for the any specialist opinion, cardiologist opinion. Even if not available, okay, refer. Referral is a very good thing. Never think that I'm losing my patient. Always think I'm saving my patient. Okay, by referring her to the tertiary care or say cardiology center or anybody. Okay. So chest X-ray, biomarkers, echocardiography, angiography, angioplasty, cardiac CT scan, cardiac MRI, CT pulmonary angiogram, and VQ scan. Now let's take all these one by one. ECG. We will see ECG. We will see changes, right? I'm sure all of you guys have seen ECG. We do have chest leads, V1, V2, 3, 4, 5. We do have long lead, limb lead 2. Then we do have long leads, 1 AVR, 2 AVL, 3 AVF. If it is inferior wall MI, we will see changes in 2, 3 AVF. If there is lateral wall MI, we will see changes in 1 AVL. If there is any septal problem, okay, septum problem or any other problem, we may see changes in AVR along with chest leads. If anterior wall MI, we will see problem in chest leads. Septum is going to be, the V3, V4, okay, and V5. All right. Long limb lead 2. Sometimes, the cardiologists, they only go for long limb lead 2. Long, because, we do have, the leads. I'm sure all of you guys have seen ECG machine. Yeah. So we do go for limb lead, okay, 2, number 2, okay. And then we are going to see the changes because this is going to be a complete pattern of ECG. So many cardiologists, they do prefer long limb lead as well. So they will see changes and they will just quickly comment and they will quickly diagnose and do the treatment. All right. Then chest X-ray. Per se, there is no specific sign of ACS on chest X-ray. However, if you feel that patient is going through, the failure, you will have, the batwing sign on, the chest X-ray, because, of course, if it is a left ventricular failure, the pooling back is going to be into the pulmonary circulation. You will see pulmonary edema, venous congestion, pleural effusion, septal lines, and this is going to be that. So in pregnancy, if at all you feel that patient is having signs and symptoms of left ventricular failure, so if there is going to be left ventricular failure, patient will have pulmonary problems. You will see, the crepitations, you will see, very fine cracks basically in the pulmonary edema. Okay. So this, of course, will come with the practice. So even if you feel anything, in the chest, if you have heard through stethoscope, and if you can even differentiate from, the normal, even if you see that something, some abnormal thing is there, refer the patient. If you feel there is a strong suspicion of failure, don't treat anyone. Okay. Now comes exam part. This has come in exam as well. That what is the cumulative, the risk of radiation exposure with one chest X-ray. So the fetal dose is 50 milligyri. This has been a single best answers. All right. So if I'm reading this dog article, so I have got another point for my exam. Now comes biomarkers. Again, I will say that, because we are dealing with cardiac muscles and muscles are built up of proteins. So if there is going to be breakdown of proteins, what will happen? They will release, the some, the byproducts, some biomarker. So we will have, the couple of important biomarkers. So we will have troponin profile. I'm sure everybody is well versed of TROP-T, TROP-I. Both are intrinsic cardiac proteins. Okay. TROP-T, TROP-I, right? Very good, Humaira. So we do go for that. So TROP-T must therefore be definitively investigated. ACS should be primary diagnosis to exclude. If at all, we have to do the, this. BNP and natriuretic terminal pro-BNP do not typically have a role in the diagnosis of ACS, but may be useful in excluding other differentials, naming cardiac failure. So basically for the biomarkers, if we talk about, we do go for troponin. Okay, TROP-T, TROP-I. Then echo. Echo is going to be a rapid non-invasive assessment of structure. Echo is going to give us, the whether heart is okay, the structure is okay, whether ventricle is dilated, what is the diameter of some valve, okay? If there is any, the dilation of the ventricle, dilation of the atrium, what is the valve diameter? So echo is going to give us that. So like ECG, maternal physiological changes can be seen on echo as well. Typically, there are increase in left ventricular mass and diastolic left ventricular volume, left atrial dimension representing adaptation to increased volume. So in ACS, what will happen is echo may demonstrate regional wall motion abnormalities in a specific coronary territory. See, this can be exam question as well. So the affected region typically appears less contractile than other unaffected region. So this often but not always matches ECG changes. So echo may also help to confirm or rule out other differential diagnosis as pulmonary embolism, cardiomyopathy. However, a normal echo does not exclude the presence of pulmonary embolism, because pulmonary embolism most likely is going to be clinical diagnosis. Later on, we are going to do a couple of investigations to confirm that diagnosis. Okay, so first thing first, if patient has any sign and symptoms, we will go for ECG. If ECG has any problem, we are going to go for, the other part. If at all we have to go for chest X-ray, we can go. Okay, but that only is going to tell us about the ventricular failures or any problem, pulmonary edema. Biomarkers, TROP-T, TROP-I very rapidly, and it can be, it can lead to definitive diagnosis of ACS at times. Echo will always tell us about cardiac function. Then angiography and angioplasty. Claire, so far, 4 investigations when you are going to do and when it is going to be applicable. Brilliant, brilliant. Okay. Okay, now we will talk about angiography, angioplasty. So both are, both are going to be used for diagnosis as well as treatment as well. Okay. Now, in this current present era, for the emergent assessment of the patient with ACS, cardiac catheterization and angiography with the view of proceeding to angioplasty is gold standard. So this is going to be the gold standard treatment for AMI, of course. So this is available across UK in 24 hours a day, 365 years basis. Arterial access to direct images of the coronaries can be achieved in as little as 5 minutes with immediate progression to intervention as needed. So they are taking it as a gold standard to, do the rapid assessment of, the AMI followed by treatment as well. Now comes exam part. So angiography can be performed during pregnancy with a relatively low fetal radiation exposure of 0.075 milligauss. So if I have to make my notes, I will write down this as well. Okay, so it shows that the ACS in pregnancy is a risk to the life to both mother and child. So the emergence of radial access has further reduced radiation to the fetus compared with the femoral access and should be the default access route of interventional procedure. I'm sure you all know how angiography is being done, right? So we are going to pass a catheter from femoral arteries and it will go all the way up to the heart through, the all vessels, and then they are going to, do the management. So for coronary opacification, iodinated contrast agents are usually used. While these do cross the placenta, they have not been associated with teratogenicity. So it means we can use them, but along with caution. So fetal shielding with the lead apron doesn't reduce radiation. Another misconcept. When I was reading this dog article, I was so surprised. So they say, it doesn't reduce radiation because most fetal radiation exposure occurs through scatter phenomena. Okay. So this is how, it goes. Coronary opacification, when there are going to be opacities, calcification. Okay. Okay. Then cardiac CT, cardiac MRI, and CT pulmonary angiogram. So they will all be used in the specific condition, not as a routine. Okay. So this is important that cardiac CT will give radiation exposure to 1 to 3 milligauss. Okay. Cardiac MRI, there is no indication for the use of cardiac MRI in emergency setting. However, it can be later on as a conjunction tool in the outpatient settings. CT pulmonary angiogram, CTPA, and VQ scan. Okay, normally we call it as CTPA and VQ ventilation perfusion scan, right? So there is no role as, the per se. However, if at all we really think that patient has strong suspicion of pulmonary embolism, so in that scenario, we can go for it, okay? Because usually they are for pulmonary circulation. So CTPA gives radiation exposure up to 0.01 to 0.66 milligauss depending on scanner and protocol, and also carries a small but significant increased risk in the maternal lifetime risk of breast cancer above the background risk. The same thing has been given in the, I think, venous thromboembolism guideline as well, where we have read about VQ scan. Okay, so I think this is same. Now, we have seen the patient, we have done the investigations. Now we have to do the management. Okay. Now we have to do the management. How we will do? We will do management again is going to be angiography. Okay, so not every subtype cause of ACS may require PCI. PCI is going to be percutaneous coronary intervention. PCI. Okay, PCI is going to be percutaneous coronary intervention. So typically, atherosclerosis and thrombotic disease do, but there is a role of treating spasm and PASCAD conservatively. So we can do that. No role. If you really think that, you have to do that, that is going to be your last modality to do that. If you think that patient has concomitant pulmonary edema, in that scenario, you will do. Okay. And why are you confused in this? Because this is the last investigation you will do in the setting of AMI. Okay. All right. So you will treat with the help of angiography. Okay. And then Percutaneous angiography, because you are doing percutaneous intervention, okay, angiography, so you will do at the same time, you will relieve the thrombotic, the part, you will open the vessel, you will, sometimes what happens is that if at all this ACS is because of spasm, or this is pregnancy associated coronary artery disease, sometimes it may be managed conservatively. But if there is any thrombosis, okay, if it is clogging the vessel, so of course you need to remove this clot. Okay. So that's why angiography can be performed in pregnancy as well. So in the pregnant population, caution should be taken because there is an increased risk of coronary artery dissection as a complication of PCI in the cohort. In addition, the high incidence of PASCAD is an underlying pathology should warrant further caution. So as PCI, okay, percutaneous coronary intervention means we are doing angiography, can further propagate dissection in these patients. So be extremely careful. So in this scenario, of course, management is going to be MDT. We are going to take help of cardiologist and, of course, interventional cardiologist as well, interventional radiologist as well. And then we are going to perform this angiography. Okay, so it should be clear that pregnancy is not a contraindication of PCI and no woman should be denied diagnostic angiography and if needed, subsequent intervention. This is a life-saving procedure. That's why only 1 hour is golden hour rule. From the diagnosis to the treatment, to the restoration of, circulation. 1 hour. If you the pick it and if you just try to treat it, so you can save, the cardiac function. In the presence of hemodynamic instability, immediate intervention is indicated. So European Society of Cardiology suggest, if possible, PCI should be delayed until after the 4th month of pregnancy, allowing as much time as possible between organogenesis and radiation exposure. This also can be one of the exam question, isn't it? So per minute of X-ray screening time during an interventional procedure, the fetal radiation dose rises by around 0.0023 to 0.012 milligari per minute. So the number of times patient is going to be exposed with the radiation, that the fetus is going to have, the radiation exposure, more radiation exposure per minute. Okay. Thrombolytic therapy, because this is because of thromboembolism. Okay. One etiology was ischemia, one etiology was thromboembolism, one etiology was atherosclerosis. If it is thrombolytic, so what you need to do? You can give thrombolytic therapy to lysis of this thrombus. So what you will do? Thrombolysis served as the historical precursor treatment of PCI, and it is still used globally, particularly in setting where PCI is not readily available. Of course, if in my hospital, the 24/7 angiography is not available, so what I'll be doing? I'll be doing, the thrombolytic therapy. Okay. But the risk of catastrophic bleeding with thrombolytic is not manual. It is roughly 3 times greater than therapeutic anticoagulation. In pregnancy, of course, pregnancy is a prothrombotic state itself. Okay. So if there is going to be, the risk of bleeding, so it can be even, the more catastrophic. So thrombolytic therapy is relatively contraindicated in pregnancy because of maternal bleeding, risk of maternal bleeding, which mainly arises from the genital tract, which is going to be subplacental bleeding. It means there can be, the chances of abruption. There can be chances of normally cited, the placenta, premature separation. Okay, subplacental bleeding, because bleeding, blood itself is an irritant in the maternal fetal interface. So if at all there is going to be bleeding, it can cause, the labor. So when used to treat pulmonary embolism, thrombolysis is associated with 6% risk of fetal loss and 6% risk of premature delivery rate. And what is the thrombolytic therapy? Streptokinase and recombinant TPA. In cardiology setting, we used to give SK as the name and TPA, tissue plasminogen activator and streptokinase. So they are going to be thrombolytic agent. They are going to work at these thrombus and they are going to thrombolize. They are going to break them into pieces and then they are going to remove the, the blockage. So they are going to go through the placenta in significant amount. So that's why it is termed as it is relatively contraindicated. However, pharmacological therapy is usually, they fluctuate normally. Pharmacokinetics usually fluctuates in pregnancy and more so in postpartum period. So many medications that are routinely used in cardiology in the non-pregnant population cannot be used in pregnancy owing to cardiology, teratogenicity, because we are much more concerned for the mother as well as for the baby as well. Okay. Now, patient has acute MI, you have to treat. So acute medication, what you will give? First of all, you will stabilize women. In acute phase, you will stabilize women. You will do rapid assessment. You will have MDT, liaison, cardiology, obstetrics. This should allow thinking about how the timeline of delivery may affect immediate clinical management. Assuming, assuming the delivery is not imminent, I have just said it is relatively contraindicated. Okay. So assuming that delivery is not imminent, then treatment with loading dose of 300 milligram aspirin, subsequently 75 milligram once daily, and the therapeutic subcutaneous heparin should be started. Heparin is typically continued until the day before angiography, because from the acute event, we have to wait for 4 months at least for stabilization of the, circulation and all. Thus, should angiography be available immediately, then holding of subcutaneous heparin allow for IV heparin during the procedure. And we all know that, if we are doing subcutaneous heparin, so before every procedure, we have to bridge with IV heparin. Okay, same goes for this. So there is nothing new in this. So there is again emerging evidence that clopidogrel, another antiplatelet agent, is safe in pregnancy. And usually this would be loaded with 600 milligram and later on 75 milligram. Chest pain should be treated with analgesics. Nitrates can be used if required, but may precipitate uterine hypoperfusion. Why? Because they are vasodilator. If they are going to be vasodilator, uterine blood flow will be decreased. Eventually, it can cause problem to the baby as well. So in the presence of hemodynamic instability, refractory to successful revascularization, then support with inotropes or mechanical augmentation may be required. Okay. Then, okay, you have stabilized acutely. In the long run, in the continuation medication, you may give antiplatelet agents like aspirin, okay, and all clopidogrel. Aspirin is considered safe in pregnancy and breastfeeding. Clopidogrel has a long half-life and ideally would be stopped 5 to 7 days before regional anesthesia. Every woman should be individualized care. It has to be multidisciplinary team approach, okay? Secondary prevention medication usually include beta blocker, AC inhibitors, and statins. Beta blockers are used frequently for the treatment of hypertension in pregnancy and usually considered safe, but can be associated with fetal hypoglycemia and growth restriction. Here comes important exam question. Beta blocker, which are, the like atenolol, apart from labetalol, because labetalol is what? Alpha and beta inhibitor, okay, blocker. So pure beta 2 antagonist, they cause fetal hypoglycemia and fetal growth restriction. That's why we don't give them. Okay. However, labetalol is okay to give in pregnancy. AC inhibitors and ARBs, they are contraindicated in pregnancy because they are teratogenic. They will affect fetal kidneys. So we don't give them in pregnancy. ARBs and ARNI, okay, should be avoided in breastfeeding as well. Sometimes AC inhibitors can be used. Furosemide diuretics is safe in pregnancy in acute condition, but we can't give them in the continuation therapy. Okay. Like, for pulmonary edema, furosemide is an acute active agent. Okay. Acute agent to give to give in the pregnancy. Okay. Statins should be avoided as they have not been proven to be safe. Anticoagulants such as low molecular weight heparin and unfractionated heparin are safe in pregnancy and breastfeeding, but carry risk if given around the time of delivery, because that's why we bridge them. So careful bridging plans may need to be put in safe place for planned delivery. No. Nifedipine is vasodilator. So whichever drug is vasodilator, it will cause more problems. Okay. It will cause more problem. So vasodilators are not to be used, like GTN, glyceryl trinitrate, like nifedipine, calcium channel blocker. Okay. So basically they are vasodilators. So if we will give vasodilator, it will cause reflex tachycardia. If there is going to be reflex tachycardia, heart will not have time to pump, again and again, because heart is beating so hard, so fast. So what will happen is there is going to be spasm. There is going to be, the hypotension as well. Okay. Beta blocker, if patient has problem, hypertension as well, then yes, you can give. They are, the supportive treatment. But acute treatment is only through angiography. Acute treatment is thrombolytic therapy. All right. Okay, now comes, because we are talking about pregnancy, so when we are going to deliver the patient, another important dilemma, isn't it? So in the acute setting, the decision to deliver depends on several factors. Outside of extreme circumstances, immediate delivery would rarely be recommended. In fact, delivery would preferably be delayed until at least several weeks. And myocardial infarction TOG article says 4 weeks from acute event. And that makes sense, because heart needs to be repaired. Heart needs to be in good condition because before it ends up into labor. Okay. This allows the woman to begin to recover. Of course, in 4 weeks time, for example, or 5 weeks time from acute event, heart will recover. Delivery does not need to be undertaken before PCI, percutaneous intervention. For women with cardiac disease, it is usually recommended to deliver by 40 weeks. Makes sense that you can take it up to 40 weeks. The mode of delivery, according to the obstetric factors, but SVD, spontaneous vaginal delivery, is always recommended. And cesarean section should be reserved for any obstetric indication. Induction is safe. Prostaglandin E2 is safe. Okay, prostin, Propress, and oxytocin can be used. But with more severe or unstable cardiac function, PGF analog, carboprost, and ergometrin should be avoided, because it will cause what? It will cause sustained and strong, the vasoconstriction. That will lead to more problem. That's why we don't give. Okay, PGF2 alpha as well as ergometrin. Now comes second stage. In the second stage, consideration should be given to allow 2 hours for passive descent of the presenting part before commencing active pushing, as this can shorten the duration of pushing. Okay, so let the patient go into labor. Let the patient go into, the labor. Don't ask her to push once she becomes fully dilated. Okay, so with this passage of time again, the heart will get more time to, the fill and pump again. So shortening of the active second stage by performing early instrumental delivery is no longer routinely recommended. We can shorten the second stage if we think that patient is becoming so, the breathless, patient is not pushing, patient says, I can't do because I'm so tired, okay? Or, that she is having so many problems at that time in that scenario. But routinely, no, okay? In the case of severe cardiopulmonary shock or cardiac arrest, cardiopulmonary resuscitation should take place with the left lateral tilt to relieve aortocaval compression, because aorta, then the venous vena cava, they are in the middle, okay, in the center. So if patient is going to be in supine position, she will have hypotension eventually. You will do left lateral position, circulation will improve itself. If patient is more than 24 weeks of gestation, perimortem cesarean section should be performed if cardiovascular output is not reestablished within 4 minutes. This we know from maternal collapse guideline, isn't it? Clear, everyone? This part? This is not your job, okay? At this level, at least at part 2 level, what you need to understand is what are the risk factors, what are the types, how you are going to diagnose, what is going to be initial modality, what is going to be the initial means of treatment, okay? You're not cardiologist. You can't become cardiologist after just reading one TOG article, okay? So limit your, the energy to important exam scenarios, exam questions. Okay, clear, everyone? Very good, very good. Okay, brilliant. All right, now you have delivered one ACS patient. What about future pregnancies now? Okay, so before she goes home, you have to offer her some contraception, which we do every day, isn't it? So we have to offer them contraception. So what are the methods of contraception? Okay, how we can give them? And what are the contraindications with history of ischemic heart disease, IHD? Okay, barrier method are not recommended because they have high failure rate. But barrier method should be advised to protect women from sexually shared infection. Okay. Combined hormonal contraceptive are UK VAC4 means absolutely contraindicated. We can't give them. We can't give them. Now comes systemic progesterone only contraception. No contraindication. It means we can give injectables, we can give oral, we can give, Mirena. Okay. So systemic progesterone only contraceptive we can give. Intrauterine methods. Insert a hospital setting. Okay, this was a question, I believe. Copper IUCD, how you are going to insert in OPD setting, in IPD setting? It should be in IPD setting. Because once you will hold the cervix, there is going to be strong vasovagal reflex. Patient can have, the effect in the heart. So it should be inserted in the hospital setting because of the risk of vasovagal collapse secondary to cervical stimulation at the time of insertion with residual left ventricular dysfunction. Okay. Implanon you can give, but implanon you can give. See, progesterone contraceptives are important. Okay. Sterilization, laparoscopy may not be possible in women with severely impaired cardiac function. Severely impaired. Okay, look at this. But with mildly impaired function, plus minus, with high risk consent, it can be performed. Laparoscopic sterilization. Emergency contraception. How about this? Levonorgestrel, unipressal acetate, copper IUCD, all are safe. Very beautiful, chart, isn't it? So before patient goes home, you are going to talk her that, look, you can have every progesterone, the method. It can be injectable, it can be tablets, it can be Mirena, it can be Implanon or anything, whichever is available in your setting. However, barrier methods are preferably advised to protect you from sexually shared infection, but CHC is contraindicated. Okay. For emergency cases, you can have UPA, you can have LNG, you can have copper IUCD. All right, now comes future pregnancies. So women with pre-existing ISD, a history of ACS, and those with residual cardiac function deficit should have a careful preconception counseling, then good antenatal care. Okay, it should be multidisciplinary team approach again. So the risk of recurrence with ISD is 9%. You can round it off with 10% just to memorize. Makes sense, isn't it? So first, pre-pregnancy counseling, optimization of cardiac function. Then, later she will embark on pregnancy. Then pregnancy is going to be with, again, MDT input, and then so and so on. So medications should be adjusted to ensure that teratogenic drugs are switched to suitable alternative, effective contraception. Any pregnant woman with a history of ISD should be cared for in tertiary care unit and managed by an MDT. Makes sense, isn't it? Yeah. So women with residual cardiac impairment should be risk stratified using the modified WHO classification of myocardial infarction. So I just Googled because I'm very fond of cardiac diseases. So I just Googled and found out that we do have a very good classification. Type 1 myocardial infarction, type 2, type 3. This is just for the sake of, just understanding. You don't need to memorize anything. Type 4, type 5, and myocardial injury. Type 1 is spontaneous. Type 2 is underlying ischemia. Type 3 is because of unexpected cardiac death, some symptoms suggestive of myocardial ischemia. So we will label that infarction as type 3. Type 4, if it was because of percutaneous coronary intervention or stent thrombosis afterwards. Type 5, if a patient has had any cardiac surgery and then she has had myocardial infarction. If myocardial injury, if any injury which is multifactorial, acute or chronic, based on any change in cardiac troponin concentration. So if a patient is a case of type 2, type 3 or 4, it should be very carefully counseled and may be advised against pregnancy. I think this can also be exam question. You may get a scenario that a patient is MWHO class 3 and she wants to become pregnant and blah blah blah. So it should be contraindicated, type 3 or type 4. If the woman is already pregnant, termination of pregnancy should be discussed. If a woman decides to undergo TOP, a medical or surgical route can be chosen, but elective surgical TOP carries a low risk of failure, which may necessitate again, emergency surgical intervention. The risk assessment should be individualized. Modifiable risk factors should be, the corrected, like obesity, smoking, alcohol, glycemic and blood pressure control should be addressed. A medication review should be done. women should be advised not to abruptly stop any medication without discussion with a specialist. Okay? Clear, everyone? So this was all about ACS and management in pregnancy. If you will study that myocardial infarction talk article as well with this, things are going to be very beautiful and very easy, because that talk article, the talks about, the normal ECG, abnormal ECG, blah, blah, blah. And, things are going to be easy. Very good. Clear, everyone? Any question? Very good. Crystal clear. That's beautiful. Thank you so much. Thank you so much. Okay. So from here, what should be the take home message? Okay. Take home message should be that you have to read talk article like a story. Okay. Make a story in your head and then just, the try to, the read it. How long pregnancy should be avoided? Talk article on myocardial infarction says 4 weeks. Okay. It has to be at least 4 weeks duration. Very good, Muzdalfa. Thank you. Thank you, Mera.
Doctora, can I ask one question?
Yes.
Because today, first day for me in the group, I wanted to ask for the that one, the hard copy we can print from the group. It is enough, no need to look for, you divide the topics. That one we will study from the NICE guideline and the other one we will study from Green Top. So no need to look, it is enough, yani? Well,
Yes,
I
yes,
need to which one will...
For the sake of one module, sweetheart, if you will just study one module. So, for example, I know what maternal medicine needs. Okay. So if I'm dividing maternal medicine into 5 modules, it means in 1 month, you will study whole maternal medicine module. So can you just imagine that, the exam is not going to be from one guideline only. It is going to be collectively from maternal medicine module. Okay. So if you study, at least this bulk, for example, I think it should cover at least 80 to 90% of syllabus. Okay, you got my point? And rest of the syllabus can be covered from MedExam website because everything is given there. Okay?
My point is that one, the topics that you divide, that one we will study from the Green Top, no need to study from the NICE. This is my point.
No. Don't get it. Don't get it like this. If NICE guideline is there, that is for NICE guideline. If, the Green Top guideline is there, Green Top guideline should be there. Okay?
So we can follow what is in the group.
Yes, follow in the group. Okay,
Okay,
follow in the group. Yeah. In summary on web, it is 1 year. I didn't get your point. Whoever are you, ZU. The thing is, if you are talking about, the time frame between MI and pregnancy, it is 4 weeks. But if after MI, you have to plan for next pregnancy, so of course you need, the long time. Okay. So you need long time. Thank you, Arjuman. Thank you so much. All right. Brilliant. So for the tuberculosis in pregnancy, I know this is very long. So inshallah, we will meet some other time. And as I promised, we will do tuberculosis in pregnancy. Okay. So just give me one time, the time to just schedule myself as well. Then when I'm going to be available with you guys and we will discuss and we can, again talk. Okay. So meanwhile, if anybody has any question, can ask me or even can approach me later as well. No problem. ZU, is it clear to you now? Huh? That for next pregnancy, of course, you need 1 year. Okay. Thank you, Aisa. Thank you. Thank you so much. Thank you. Oh, yes, I will take rest. TB in pregnancy, talk article, this July 2023. Okay. All right. Inshallah, I will see you guys in some other session for, of course, tuberculosis. And I may bring another topic as well. I will tell you guys. Okay. For God's sake, try to understand what I said. Okay. Don't catch just whatever is being said in online session. 4 weeks is from acute MI in pregnancy, and then you have to plan for delivery. That's what I said. Okay. But if the after 1 MI in pregnancy, next pregnancy should be, so of course it needs time. So it has to be at least 1 year time to wait for next pregnancy, because cardiac function has to restore. Okay. Claire now, ZU, I don't know who are you. At least try to write your name properly, because it's better to address properly rather than, calling with these names. All right. Inshallah, I will see you guys. Okay. Take good care of yourself. Good night. Shabba khair. Allah Hafiz. Bye-bye.